Hey guys, Woodruff here. We just talked about chronic back pain, so now let's talk about degenerative disc disease. And so this can actually be a cause of chronic back pain, but it also is kind of its own thing as well. It's a more specific disease process when it comes to back issues. And as the name suggests, it is a problem where the discs, which are effectively your shock absorption for your spine, they start to degenerate. And so like this picture shows, they can be bulging, they can herniate, they can start to break down, they can get thin. But this one specifically, degenerative disc disease, is where they lose fluid, they lose elasticity, flexibility, and that shock absorption. And so this is the same, just kind of like having arthritis, which we haven't talked about yet, but effectively what's happening is you're losing that shock absorption. So like everything is going to be so much more painful and difficult because you don't have your cushion or your support for your spine. And so the discs start to break down and they can lead to some very severe pain, especially when they become slipped or herniated or go to the wrong places. So, okay, so this is like just an open-ended question for you to ask yourself. At this point, we've learned about acute back pain, chronic back pain, and now we're learning about degenerative disc disease. But this is a great place to pause and ask yourself, okay, like, how am I going to differentiate these? These are three good things to like maybe make a simple table over, where you just kind of break down and say like, okay, so like, what are the differences between these? And a lot of the differences are going to be like, how long do they last, or what was the onset? What kind of problems or complications can they have? A lot of them are they're going to have a lot of similar stuff. So, definitely learn what they have in common, but don't feel like you have to study each one differently. Just study what the differences are, and then what's the big picture for back pain, how we treat it. So priority assessments, these are going to be very similar to what we just talked about with chronic back pain, but the differences that you're going to note is the pain is going to be different in that it can radiate. Radiating pain is something that's a little different with disc disease, because now we're getting into nerve problems. Chronic back pain is usually, not always, but it can be like a musculoskeletal or muscle aches, that kind of stuff. Whereas this, we're dealing with nerves and getting deeper into the spinal column. So that some stuff can really start getting out of whack and can lead to not just pain, but strange pains, or like that radiating pain. And radiating, think of it like shooting. Radiating is where it's starting somewhere and going somewhere else. So commonly they have low back pain, but then it's going to be shooting or radiating down their buttocks or below their knee. So it can be very uncomfortable. We also want to assess for other problems, but because we're dealing with spinal issues here, they can also have, we're talking about like lower back, we have to think about what is the function of the lower spine, help to, the fancy word is innervate, but what part of the body does the lower spine talk to, or what function does it serve? And most of the lower spine talks to your lower extremities and helps them to get the blood flow sensations and nerve impulses and stuff like that to them. So when it's not working, this patient may complain of numbness and tingling. And the way that this might actually present, I've seen a lot of patients that come in with back pain issues where they'll complain, they'll be like, oh, my foot is numb, I can't drive. A lot of times it can affect their ability to like just do day-to-day stuff. So you want to ask about paresthesias in their lower extremities. And then the other function that the lower spine does is it helps to send signals to your bowel and bladder for it to empty. So they can have it can go both ways. It can either go that they're retaining stuff and they're having urinary or bowel retention, which is constipation, or it can be incontinence, where they're having urinary incontinence and then they're having fecal incontinence as well. So it can go both ways. A lot of times it leans towards retention, but it definitely can go both ways. It's going to have the same diagnostics like we talked about before, the straight leg raising test and then the MRI CT. This is going to be pretty much the same, the better or worse. Everything's about it getting better is about the pain, functional ability, range of motion. But the difference is here for worse is that a decreased or inability to complete basic daily activities. So like I said, like if they start to be unable to like drive their car, take care of themselves and stuff like that, that's when we're going to start to look at, hey, things might be getting worse. We always want to assess for new or different paresthesias or sensations. and then check on how their bowel and bladder are doing. Now, one thing I want to mention is I've talked about degenerative disc disease as a low back issue. Degenerative disc disease can actually happen in any part of your spine. It just most commonly happens in the lower. So you can actually have cervical degenerative disc disease, and it can affect your upper extremities and things like that. So just know this is not all inclusive, where this is the only way they present, but we usually focus on the lower back because that is 9 times out of 10 where most people have their degenerative disc disease. When I say 9 times out of 10, I am not a professional. So I'm throwing out statistics like I really know. Like, you do not want my Guinness Book of World Records of what I think to be true. Anyway, so this is that straight leg raising test again, where they start at 90 degrees. And once they get below 60, that's usually where they start to feel that tug, that pain. That is sign of like nerve irritation in their lower spine. So there is surgical and non-surgical options. So first, let's talk about more conservative options. Effectively, this is going to look the same like chronic back pain, physical therapy, stretching, body mechanics, balanced activity, and rest. And then the one thing that might be a little different here is that, and I mean, people with chronic back pain can definitely have this too, just depending on the cause, is that we might start using spinal braces. I don't know if you remember from fractures where we talked about where they have that kind of wraparound brace. So sometimes they can have those as well. They can just provide stabilization and help to decrease pain before or after surgery, or maybe if they're trying not to have surgery. Heat and ice, massage, the TENS unit, which is, again, it's the one that I talked about where it doesn't actually change the fact that you have pain. It just stops your body from receiving the signals that you're hurting. A lot of the same medications, steroids, and that would be like sometimes when they're having a really acute attack, they might need systemic or oral steroids. And remember, if you ever see anything, not local steroids, but the systemic ones, remember, we're worried about blood glucose. They can have weight gain. They can have, their immune system can be compromised. So just kind of remember that with steroids. They can get sick more easily. They're full of sugar and they're super hungry. Anyway, what do you call them? Also, opioid analgesics, muscle relaxers can help. We talked about muscle relaxers when we talked about fractures, so you might want to review those if you have not yet. And then we can also do steroid injections just like we can for chronic back pain. Now let's talk about some back surgery. So compared to just chronic back pain, more often with this disease, people are going to end up needing surgery. So there's a couple surgeries listed here. Now, remember, we don't go to, at my school, that we don't go too in-depth into all these procedures. Like, you don't need to understand the patho or how these procedures actually work. What you do need to focus on is what you're going to do as the nurse. But just so you know, like some of the surgeries or procedures that can be done, what's called a laminectomy, which is where they remove a disc that might be protruding, a discectomy, which sounds like they're removing a disc, but what they're actually doing is like if there's a nerve root that's like kind of compressed, they decompress it. And a fusion is like a fixation. It's like where they fuse part of the spine together. So it's like, I know it's going to sound strange, like why would you fuse part of it together? That's going to limit the range of motion, but it actually provides stability to make things easier for them. After surgery, there's going to be special positioning. Now, a lot of this is going to look like the positioning we already talked about, the side lying with the pillow in between the legs, or the knees elevated with the pillow. Remember, I like flexion with I like flexion in their hips, and I like flexion in their knees to decrease pain with spinal surgery. But the other thing that we're going to do is what's called log rolling. I think I have a video on the next slide, but if you don't know what log rolling is, I'll talk about it here in a minute. But it's a special position just to make sure that we really don't want them twisting or having any torsion. So I do like flexion in their knees and their hips, but I do not like twisting or turning or any, like there's nothing where I want them to be kind of their spine kind of getting that side to side twist. I want everything to stay very aligned after surgery. And then, of course, just pain management, repositioning, things like that. They can do the heat and cold application. So I have 2 videos here. One is just of how do you get a patient in and out of bed with log rolling precautions. And a lot of it's in the elbow, like where you're going to, like, they're going to turn on their side first and then use their elbow and then the side rail to push themselves up. But you don't want a lot of twisting themselves up. And then the second video is when you have a patient that is completely immobilized, like in a ICU is more often when we have this, where they have C-spine precautions, and you have your 2-person log roll. And the key for this is going to be all about that there's 2 people and they cross their arms. So like if I put my arms on the other side of the patient, someone else puts their arms, like you can kind of see it here in this picture, how their arms are intertwined to provide really good stability effectively. Again, I don't want any twisting, turning in the wrong direction. So log rolling is a good thing. Let's see if I can get on here. So what am I going to, I just want to make sure I didn't skip anything. All right, no, don't do it, come back. All right, there we go. As the nurse for conservative care, again, this is non-surgical, what's my role? It's going to be the same as chronic back pain, stretching, yoga, moving some, but not too much, teaching body mechanics, regular activity with rest periods, and regular pain assessments. But if they're not going to have surgery, I always want to be looking for things to get worse. Like, that as things go on, there can be more pressure on their nerves and worsening pain or functional ability. So I always want to check in. So some people, they really struggle with this and they'll continue to drive or do other activities that are probably not safe, like operate machinery and things that they probably shouldn't be operating. So I just want to always kind of check in with them, try to create a very trusting relationship, make sure that they're going to be open and honest and tell me when things are changing or getting worse. Especially want to look for those bowel and bladder changes, the general functional abilities. Remember those paresthesias, things like that are what I'm going to be looking for. So let's do because we still need to go into nursing. Oh, 1 second, sorry. Suri's trying to get all angry at me. We still need to go into nursing interventions for what do you call it? When they have spinal surgery. But in the meantime, let's do a quick activity. So there can be a lot of complications after spinal surgery. We are getting in the spine, which sends all of the signals to the rest of the body to do basic functions. So we're going to look through these and we're going to say which of these are indicators of a complication after spinal surgery. So we're going to look at this like a true false and make our way down. And then we'll talk more about the nurse's role for a client who has had spinal surgery. So if client is complaining of a new numbness in their left foot, is that a sign of a complication? Well, if it's a new numbness and they've just had surgery, that sounds like something I would run a report if there's any sort of changes to their neurovascular assessment. And that is, by the way, one of your top assessments after a spinal surgery is going to be a peripheral neurovascular. And what I'm talking about there is usually, especially if we're talking about lower spine, it's going to be the legs and feet. If we're talking about a cervical spine, then it would be like the hands. But yeah, like I said, most of the time it's low back. So we're talking about any sort of change to the neurovascular assessment to their feet. So we're definitely going to say, yes, I would need to probably report that, let the doctor know. Client has a moderate amount of clear drainage on the dressing. So most students would say, no, that's not a complication. Clear is good. It's not bloody. But here's the thing. When you're dealing with the spine, as much as we don't like crazy amounts of blood loss, we also don't like clear drainage. But do you know why? What else could be coming out of the spine, other than blood from the incision? And if you said CSF or cerebral spinal fluid, you would be correct. So the reason that this is concerning, I'm giving a thumbs up, not because it's good, but that it is a sign of a complication is that anytime a patient has clear drainage on their dressing, I'm actually going to do a glucose test on it and see whether it is CSF or not. You'll learn more about CSF tests and stuff like that. We are not going to test you in depth over how to test for CSF or anything like that, but just know we do not like clear, and CSF can show up as clear or like light yellow drainage on the dressing. And we definitely want to look for this because a spinal leak, if they're literally losing the lubricating fluid in their spine, it can lead to some very serious neurological emergencies. So it's okay to have some serosanguinous drainage, some sanguinous drainage. It shouldn't be too much. But we do worry about clear or light yellow drainage after spinal surgery. The next one is, so far I'm concerned about the new numbness. I'm concerned about the moderate amount of clear drainage because it could be a CSF leak. Client has a 6 out of 10 pain in their back. Well, this is like, because really this question is seeing is like, is this expected or a sign of a problem? 6 out of 10 pain in their back, that's actually pretty average, if not that bad. Most patients after their spinal surgery may be complaining of 8+ pain, in their back. They can have a lot of pain. I would worry if it said something in this statement that the pain's getting worse or it's not relieved by medications. That I would need to report, but just having pain in itself is not a complication. Client has not had a bowel movement in 3 days. So for most of us at home, we're like, oh, they fine. That's not a complication. That's just constipation. But in nursing school world, we consider constipation a complication. So, and especially after spinal surgery, because it's all about movement and getting moving, we're going to be very concerned about a patient who hasn't had a bowel movement in 3 days. We usually start least invasive first, like fluids and fiber, but then we start to really step it up and start using other things if that's the basic stuff doesn't work. So yes, so we have 3 complications so far. The complications are the new numbness in the left foot could be a sign of an issue like with the surgery, or maybe an issue like with their nerves, like could have gotten messed up. The second one we talked about the CSF leak, and then constipation. So just start thinking about, okay, these are the actual signs and symptoms of the complications. Oh, what do you call it? Yeah, sorry. What do you call it? My husband's heading home. I asked them to text when they were leaving so I don't get interrupted. So anyway, where was I? Yeah. So you want to always think about, here's the signs and symptoms of a complication, but what are the complications I can have after spinal surgery? Because it could definitely go a few different ways explaining these, like in a question, we could ask you which of these signs are scary. We could ask you what are complications of a spinal surgery, etc. The next one is client does not feel up to ambulating. So, you might say, ooh, psychosocial complication. Now, this is completely normal. Like I mentioned, a lot of times patients with back pain, they do not want to get moving. They just want to stay in the same position. And so, at the end of the day, we really just want to encourage them to get up and get moving. And, the funny story I have, this wasn't after a spinal surgery, but it was after a GI surgery. This patient would not get up and move. They would not ambulate. And it's so key for GI surgeries too, to get gas moving. And so eventually, like I was in cahoots with their family, and we just convinced them that they stunk, and they finally got up and took a shower. So it was the only way we could get them to get up. I'm not saying call your patient smelly, but I'm saying it worked. So I'm just totally joking. That really did happen, but I'm just being funny. I know that some people listen to this and English might not be their first language, or they might not always get my jokes. And for that, I'm very sorry. But I'm really just full of crap. Anyway, this is not a complication, but it is something that I would need to do. I'm not going to call the doctor and be like, the patient's not ambulating. I'm definitely going to need to intervene, but not necessarily, it's not a complication or a result of something going wrong with the surgery. It's just hard to move sometimes. Persistent headache. So this might not seem so scary, but this is actually a sign of a CSF leak. So especially a severe headache could be that they're losing too much CSF. So this is also a sign of a complication. Purulent drainage from the surgical site. That is absolutely a complication, because there's no reason to ever have purulent drainage from any surgical site. There's never like, it's okay to have a little bit. Difficulty urinating. This is another thing, just like the constipation. Remember, we talked about they can either have trouble holding it in or trouble getting it out. So needless to say, changes to neurovascular, sign of a CSF leak, constipation, or like bowel complications, bladder complications, unrelenting pain or changes to pain. We'll want to report all those signs of infection. These are all possible complications. So as the nurse post-op, I'm going to encourage mobility, appropriate body position. I'm going to teach them how to utilize the brace. This is an example of the brace. And a lot of times people do not put them on very tight. Now you should be able to breathe with these, but it's okay if it's a little difficult. Like, it should be super tight because it's providing literally the stability so that their spine does not, I don't want to say break or snap in half because that's a little dramatic, but it's providing stability for the thing that helps keep them walking. So we do not want to mess around with this. But you want to make sure they know how to put it on and that they put it on right. So usually when they're in the bed, they don't have to wear it, but once they get up and they're ambulating, they do. So you want to make sure that they know that, because some people try to cheat the system. Pain management is a big part post-operatively. Like I said, there's all this complication. So watch the peripheral neurovascular, watch for infection, watch for CSF drainage. And we talked about that clear, slightly yellow drainage as being CSF. constipation or, other urinary complications. Some of these patients may have Foley's. So I want to watch those devices and everything closely, watch any drains that they have coming out of them, how much is coming out. So warning signs: severe headache, low blood pressure, fever, high heart rate. So that would be like a sign of sepsis. If there's a new muscle weakness or paresthesia, or a new onset, like we talked about, bowel bladder, or unrelieved pain, these are all signs something is no bueno, and we need to get moving and get them taken care of. All right. I think that's it. But yeah, this is kind of it for the back problems. We're going to get into the arthritises now. But effectively, remember, back stuff, we want to get them moving, but not moving too much where, they're going to be uncomfortable and hurting. And we want to make sure we're managing their pain, alternative pain techniques, because a lot of this is chronic and they're going to need extra support, using appropriate equipment, braces as needed, looking for those complications and doing a very good neurovascular assessment, seeing what other symptoms that they might have. I think that sums it up. I'll see you for arthritis.